Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. Join us this week where Heather Dyck, a patient partner and advocate for post-operative delirium screening, and Dr. Liam Dowling, a PGY2 anesthesia resident at the University of Saskatchewan, discuss post-operative delirium, including manifestations, complications, and management, both from a physician and patient point of view. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come take a break with our host, Anesthesia PGY2 Sebastian Turcott, and a multitude of brilliant and insightful guests as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Hello, everybody. Thanks for joining us for another episode on Airway Breathing Conversation. My name is Sebastian Turcott, for those who don't know me. And today we are joined by Dr. Liam Dowling, who is one of my colleagues and co-residents here at the U of S, as well as Heather Dyck, who is one of our patient partners with the department. And so lovely to have both of you. I think most of this episode will be driven by Liam and Heather today, and I'm just here to learn, honestly, from both of you about a topic that I'm not super familiar with and super excited to learn more, which is post-operative delirium, which is part of Liam's resident research project, right?
Yeah.
Yeah. Okay, sounds good. So Liam, why don't you tell us a little bit more about yourself and sort of what got you interested in this topic?
Yeah, so I'm originally from Ontario. I am a Saskatchewan transplant, born and raised in Kitchener, Ontario, and then did my undergrad and medical training out in Kingston, Ontario. Mm-hmm. For those who don't know, Kingston's demographics are sort of university students and older retirees. So I got a lot of exposure to sort of this topic. And I really became interested when I did a geriatrics rotation during medical school and met a lot of patients who had post-operative delirium. And I'd already been interested in anesthesia, but to sort of see that sort of after OR experience was very informative and eye-opening for me. Mm-hmm. And then the other thing that really got me into it was my grandmother, my Nana, had an experience of delirium after a surgery. Okay. And so that was very sort of concerning to our family to see that happen and really saying what better things can we do as operative people, anesthesia surgery, to help sort of educate people and reduce the risk of it. Okay. And so that's sort of how I got interested in this topic. Yeah,
very cool. Nice that, like, you have a personal anecdote, but then, clinically still very interesting and something in anesthesia that we don't necessarily see a lot because we see the patients when they wake up, but then after that don't always get an opportunity to follow up on them so much.
Absolutely.
Why don't you tell us a little bit more, like, what is post-operative delirium? How does it work?
Yeah, so post-operative delirium, as the name implies, is somewhat of a confusion or like a mental change after surgery. Mm-hmm. So for some people, it can present in different ways. So it can either be confusion, memory issues, lack of attention. Lack of attention is a very big sort of key feature when we look at sort of our classic diagnostic criteria. And the other thing is that it fluctuates and changes over time. So it's not always consistent after surgery. That's sort of characteristic. And for some people, it can last from one episode, it can be a couple of hours, can last to days and sometimes weeks after surgery. Okay. And there's somewhat of a bigger conversation about what's called post-operative cognitive dysfunction, which is maybe those more long-term effects after a sort of the stress of surgery. Okay. So it can happen to a whole bunch of different people, but mostly we think of people over the age of 65 who are coming for surgery are at risk because their brains are a little bit more vulnerable than a younger person coming.
Yep. Okay. And so what kind of timeline do we look at in terms of post-operative delirium? Because it sounds like it can last a day, it can last a couple of weeks. Is there like, say a patient looks okay maybe the first day post-op, but then later on in their hospital stay maybe deteriorate a little bit? Does that still fall under that umbrella?
Absolutely. So it can start immediately post-op, like even in our PACU, our post-operative like care unit, that's where it can even start presenting for people. Sometimes it's already started in hospital prior to coming in for their surgery, and the surgery increases that risk. But yeah, it can be fine even a couple hours to days after surgery, and then it may just happen. And it's hard hard to predict that exactly.
Okay.
But like I said, it's a very fluctuating experience
Okay.
where it's not just, it's going to happen on this day. It could happen really any time that you're in hospital after surgery or just in hospital in general.
Okay. And then you mentioned that age greater than 65, one of the risk factors. Any other major risk factors that you've seen through your research?
Yeah. So the classic sort of teaching is, as you mentioned, age over 65. There's individuals who have a baseline cognitive impairment. So those are maybe individuals who've sort of started slowing down in life, people who have Alzheimer's, Parkinson's, or other sort of cognitive delays or challenges. Individuals who are very frail. So those are people who maybe need assistance with their day-to-day activities or maybe need help getting groceries. Like I said, people who are starting to slow down in life, I find often is something that is a risk factor for it. And then there's sort of your other stuff where if you're coming in for a major surgery, so heart surgery is pretty high risk for delirium afterwards, and as well as orthopedic surgeries like hip fractures is a very common one.
Okay.
And then other sort of things, if you just don't have a great heart, lungs, or maybe a more sick person, you take a lot of medications. If you smoke cigarettes, drink alcohol, all of those can increase your risk of getting delirium after surgery.
Okay. That sounds like a really good overview. It sort of sets the stage for the rest of our talk.
Yeah.
And then we'll get you off the hot seat and we'll introduce Heather again. So Heather, can you tell us a little bit about yourself? What got you interested in becoming a patient partner here?
Well, my journey with dementia with parents goes back quite a few years. Dad was diagnosed first at the Rural and Remote Memory Clinic with normal pressure hydrocephalus.
Okay.
And then Mom was convinced she had a problem. And we got her through that process as well of the testing. And at that time, they said mild cognitive impairment. So that's what her official diagnosis was at the time of her fall. And then she ended up with totally undiagnosed post-operative delirium.
Okay. Yeah. And can you tell us a little bit more about what that experience looked like with your mom?
Well, she fractured her hip at home, laid on the floor for about 7 hours before they thought to call an ambulance.
Okay.
Because Mom and Dad was absolutely convinced she'd be fine if she just laid there for a little bit. Didn't call the family.
As we hear from a lot of patients, unfortunately.
Yeah, did not call the family. And then she waited in hospital for 3 days for the surgery.
Wow.
For a place on the roster. And she wasn't, I don't think she was any worse in hospital. And then the day of the surgery, they didn't do the surgery until about 6 o'clock at night. So I stayed there with my father until she was back in her room and really dopey. But then I took him home because he had his own issues to face. And I got a phone call at 12:30 in the morning. We don't know what to do with your mom. She's not herself. She's trying to get out of bed. She's just not reasonable. She's not listening to us. So I said, well, just keep her as calm as you can. I'm coming. I live about a half hour away. So I went in and the first thing I did was give her glasses and talk to her and turn a light on and put things as normal as I could. And once I'd spoken with her for about 5 or 10 minutes, she was, oh, Heather, something's wrong. And she couldn't figure out she'd had surgery. She totally forgot that. But I told her what had happened and that she was pretty confused. And I was going to stay with her until she was sound asleep again. And then I would have Dad back first thing in the morning. And I probably spent about 3 hours there total that evening and then went home and told them to call me if anything happened. And when we went back the next day, she was still pretty confused. I had to go over again what had happened, that she'd had surgery, that she'd fallen. She knew my father and myself. When my younger sister came in, she didn't know who she was. until it was all explained to her. And when I wasn't there, the staff was not quite sure what to do with her, because she'd go from being totally reasonable to trying to crawl out of bed. And physio had not gotten her up yet, and they just didn't want her moving about until that had happened. And she was like, let me go, sort of thing. So, and she was a nurse in her past, and she hadn't practiced in many, many, many years. She was a nurse's aide. And she would wake up in the middle of the night and think she had to go get ready for work because there was a hospital. And it was an interesting journey. She spent 12 days in hospital after the hip surgery, which was unusual, but she didn't heal fast, and she didn't get over the delirium fast. And when we took her home, it was before we wanted to. Dad was terribly concerned about taking her home, and she was going home. So he agreed, and then I spent every day with them. I bathed her, I got her dressed, I gave her meds, did her heparin shots, did everything that needed doing. And 3 days after she went home, my dad didn't wake up in the morning, and the stress had killed him. So then she moved in with us, and she didn't ever really quite recover to where she was before the surgery. It went from mild cognitive impairment to not really being trusted at home. Mm-hmm. She wasn't happy, but she lived with us for 6 months, and then we put her in assisted living, and she hated us when we did it, and she was happy there after the first couple of weeks. So.
This is my first time hearing this story, and I am very touched by your story. Thank you for sharing. I'm sure it's not easy to share that. No. And it sounds like a pretty challenging time for your family.
It was.
Yeah. To put it mildly, I suppose. Yeah. I guess I did have a question around the surgery itself. Okay. Did you notice, just in terms of your mom's mood, behavior, different things like that, did you notice a difference before the surgery versus after? Anything like that? Or
a different location, because she already had mild cognitive impairment.
Right.
It wasn't surprising that she was slightly more confused, more quite not with it, but not a huge difference. So yes, I noticed. I was probably the only one that noticed.
Yeah. Okay. And, were there any aspects of her care, and I'm sure you can name a few, that you thought could have been done a little bit better for her, just to help support her, in that time, which obviously sounds like it was very scary for your family, but also for her too, while she was in hospital?
Well, she was never diagnosed with post-operative delirium. And as far as the mild cognitive impairment, since we didn't call it Alzheimer's, the staff kind of just passed it off and went, so she forgets her keys. And it was more than that. And things like turning a light on for her when they come in to talk to her at night, that's just common courtesy. And those things weren't done because they didn't want to wake her up, because then she might not want to go back to sleep. But they wanted to wake her up to make sure she was okay. So things could have been done a little bit better. But without them paying attention to what she already had, and of course, overworked on the ward and understaffed, it wasn't a happy time for my mom. It wasn't a good time for the staff, and it definitely wasn't a good time for the family either.
Yeah. It sounds like, just as a system as a whole, this is a challenging, this post-operative delirium can be very challenging for everybody involved to try and manage, for patient, staff, families, like you mentioned. And I guess I can throw this question to both of you, but are there, strategies that either of you know of that can sort of help manage that a little bit better on the wards with patients?
Totally. What I found very interesting was that when you got the call that she was confused at night, the very first things you did were put on her glasses, like turn on the lights and just talk to her, which very easy in medicine. And we all know it's sometimes easier or more convenient to maybe give a medication or just do something that's medical or look at medical causes for things, as opposed to just basic, like you mentioned, courtesy of making sure that lights are on when you're talking to people, that they have their hearing aids in and their glasses on. I try and do it in the OR when people wake up. Once they're sort of settled, put glasses on. Because I can't imagine it being in the middle of the night at like midnight and someone's getting close to your face, you can barely see, and they're just talking to you. Like with my Nana's experience, she had some hallucinations in hospital. And the common one was, there's a man in my room that was coming in. And we were sort of like, well, is this a hallucination or was this just your nurse that was coming in and you didn't realize who it was because you couldn't hear what they were saying? So like when it comes to basic stuff, like environmental, having people near windows, I say to patients and families, come visit them in hospital as much as you can. Having a familiar face in an unfamiliar environment is going to do more than any medication I would ever provide. And so that should be the foundation, I think, and building blocks of how we sort of look at these challenges of just things that are very simple to do that you would do for everybody else. So I'm really glad, like it's great to see that, like, because that seems so obvious, but sometimes you get lost forest versus trees when we work in healthcare, I find. Well,
and overworked staff is an issue. It's a huge issue. And that's pretty common everywhere. So.
And then I think the other thing was you sort of touched on this sort of initial diagnosis of mild cognitive impairment, which like is a technical term within the world of psychiatry and geriatrics. But I think it was sort of like a lack of recognition that your mom was at risk, period, right? That you had this diagnosis, which to my ears would make me think that she's quite high risk for getting delirium or confusion after surgery. But that maybe wasn't talked about or communicated with the team, or they just didn't recognize it, or...
I don't think they knew about it.
Right.
Quite honestly, this was a few years ago now. And yes, it was out there then, but since this research project started, I've talked to a number of medical personnel, and most of them don't have a clue. It's not in their training. And until it is, or something is in the patient's hands, which now it is, there's really no way to know. And like you said, anesthesia doesn't see them often after it. Unless there's something to do with pain control, they're not there. So,
which can certainly be a challenge, especially when, as anesthetists, we're meeting the patient for the first time. We don't necessarily know what their baseline is. I'm assuming I shouldn't assume, but I've seen patients come into hospital before with a fractured hip, and they're not maybe quite themselves. Like we'll meet their family members in holding, and it's tough to gauge what their baseline is. How do we sort of try to maintain that as best as we can to get them through the surgery and feeling more like themselves after the fact? And so, it's certainly a challenge, and it sort of sounds like really need a big team approach when it comes to this, right? The MRPs or the staff, the staff physicians, the anesthetists, the nursing staff, families, having everybody involved. It's sort of the sense that I'm getting from both of you, just as a really important key step in all of this.
It's called patient and family-centered care. And yes, it's what we believe as the SHA. It's what patients need. It's not always possible. It's not always remembered. And it's definitely not always practiced by everybody.
But I think it's so important to continue this message and that more people hear it, right?
Including seniors. If I'm not quite over that hump yet, but when I get to it, I would hope that before my next surgery, it is brought up to me. I hope it's brought up to my husband. It shouldn't be a surprise. And if we can educate the patients and their families or their friend or whoever their important person is, then that's half the battle.
I'm curious, what would that education sort of look like to you? And I think that would really help me in my practice.
Okay.
Like, what should I be looking to tell families what to expect?
Well, we have developed a pamphlet, and there's posters going up in
Nice.
preoperative assessment clinics.
Yeah.
Although not every patient gets to a preoperative assessment clinic.
Yeah.
Like fractured hip doesn't do that.
Right.
But if they're given the pamphlet somehow, it helps. And for an anesthesiologist, just going over some of the basic guidelines. You don't want to scare them. You don't want to worry them, but you do want to prepare them. So it's everything you can know, especially as the family before, is good. Because the person going through it is not going to know it.
Yeah.
But the family does. And that's who usually can see the little changes.
Okay. And I think we'll touch on a little bit more of this, but I also just wanted to ask Heather, like, how did this experience affect you, like, as a caregiver for your mom and for your dad, especially too? It seemed like.
Well, Dad didn't really recognize that. He just thought that she was under a lot of stress because it was so long before the surgery. And that's what he put it down to. How it affected me, I guess, well, it uprooted our lives because she moved in with us.
Yeah.
And I have my own health challenges. I have MS. I have a couple other things going on. I still had kids at home at the time, and son and daughter-in-law and grandson living in our basement. So it was busy. And I will have to say there were a couple of benefits to having Mom move in, though. And my grandson and his great-grandma were best buddies. So that was wonderful.
Yeah.
So
cool.
Yeah.
Okay. Awesome. And so we've sort of touched on a little bit of what's being done in terms of trying to improve the awareness education around post-op cognitive delirium. And can you guys touch on that a little bit more?
Yeah. So right now we're sort of in a education and awareness sort of stage. So earlier this year, the anesthesia department hosted a series of talks about sort of post-operative delirium, risk factors, how to assess it and manage it as physicians. And so that was very physician directed. And then I worked with Heather on creating pamphlets and posters to be given to patients preoperatively who are maybe higher risk for those for delirium. And then this podcast is part of that as well, as part of that sort of educational campaign. And that sort of is concluding in the next couple of weeks to months. And then the plan, as I understand, is to work on a pathway to really find these patients who are higher risk, assess them before they have surgery, and then have them go so that these sort of common sense practices, things that we know are evidence-based and work to identify and reduce the risk of delirium, are implemented for these people, and really trialing and seeing how that works within a hospital system. Because it's very easy to sort of know what works, but how do you actually implement that in practice is really hard. And so that's sort of the next steps here at RUH and across areas of Saskatchewan.
Okay.
And it'll be in the larger hospitals first, because that's where the training goes first. Mom had her surgery in Prince Albert. That is not the smallest hospital that does hips and knees in Saskatchewan. So hopefully, eventually, it sooner rather than later, the news gets out to everybody, and especially for those patients that are at high risk, they can maybe find the extra time to spend a little bit extra on them. Ideally, we'd all have that care. In the real world, doesn't quite work that way, but we're working at it.
Yeah.
Slowly chipping away.
Yeah.
And I can just see, how passionate you are about this and how important it is. And I think it would have such a huge impact for patients moving forward. Liam, you mentioned an assessment for patients prior to their surgery. What does that sort of look like?
So there's a variety of things that can be done. So there's more formal assessments. There's MOCAs and mini mental status exams. Those are very formal things. For me personally, in my practice, I just talk to people and really get a sense of what they're like at home. So one of the questions I love asking people is, do you still grocery shop on your own? And that is a very telling question, because if someone can come up with a plan and drive themselves to the grocery store and physically walk around a grocery store carrying groceries, because I know they're so heavy. I go to Costco a lot, so I like big slats of stuff. Yeah. But like, if you're able to physically do that, bring it home and cook, like that says to me that your brain is working pretty well for where you're at. And so I may be less concerned. With people over the age of 65, I still tell them that you might take a bit longer to wake up from anesthesia or feel more like yourself. Mm-hmm. But for those people, when I hear they're slowing down, people are starting to help them, along with the other risk factors I talked about. Then I'll have a more frank conversation about what that looks like. So there's not necessarily a one-size-fits-all tool that we can do, but it's really using that sort of clinical expertise and just talking to people about what they're like at baseline so that we know, right? Because it's easy to say, well, this person had dementia and this is just what they're like when they're maybe too sleepy or or more aggressive in hospital. It's easy to say, well, that's just what they are. And so having that conversation with the patient, with their family.
With their family.
Yes. So that you know sort of what that looks like is just super helpful, I think.
Yeah. I agree. Just a conversation. As soon as you start talking medical words to somebody who doesn't understand medical anything, it's not in their best interests. It might make you feel good, but it sure doesn't make them feel good.
Yep.
So with Mom, she would have understood some of the medical words. My dad would not have.
Right.
So it's important to just use plain English and speak at about a grade 5 level, just to make sure everybody understands. And if somebody is not an English first language, see if you can't get somebody to talk to them in the language that they understand best. Because when they are not well after surgery, that's the language they're going to be able to talk in the best and understand the best. For an Indigenous person that comes out of the far north, because they fractured a hip or something like that, and they are far away from their traditional foods, their traditional medicines, anything that's familiar, and if they're fortunate, a family member or two might be around. But again, it was an emergency situation. They might have been flown out. The family might have driven down. Just finding out what language they speak and having somebody that can speak that language to them, that is that culture, that understands the culture, is helpful. We have a lot of new Canadians. Same thing. If they don't understand English as their first language, and that's what we're speaking, especially if we happen to go into a few medical terms, it's wasted on the people that it's meant to help.
Yeah, very fair. And then I feel like we, as practitioners, feel like we did a really good job of explaining what's about to happen.
Yes, I went into told them all about cognitive dysfunction and delirium. And all
I warned them about it, but really, you probably just confused patients and their families a little bit more.
Yeah, exactly. So keep it simple, keep it honest, and say it more than once if you get the opportunity.
Right. Yeah. And then Heather, is there anything that patients or their caregivers can do, maybe in lead up to an elective surgery, that they can just prepare themselves for?
Yeah. They can bring pictures of their loved ones, be visited often by their loved ones or their neighbor, unless they're, enemies, which can happen. You can have the wrong person on the list. So it definitely does happen. But mostly it's having familiar things with them. If they always have this house coat when they're in bed, give them their house coat. Yep. Bring the pictures. If they use a smartphone, have it there. If they don't use a smartphone, have a tablet there with you and show them pictures of their grandkids, show them places they've visited, show them places of their home. Show them what their bedroom looks like. Look, it's waiting for you when you're done and ready to go home. And and your old cat's being looked after. See, here's a picture of Snoopy. And just the things that are familiar and common. And definitely visit often. You don't have to spend all day. They're tired. They need to rest too. But if you come often, it definitely helps.
Okay. That's such an intriguing way of looking at that, because I always tell patients, the hospital is not a familiar place. How do we make it more familiar? I think that's such an easy way, but like I've never even thought of it that way. That's so cool.
You've never seen, some people will on the windowsill, they'll have like their family photos.
Yeah.
And I actually had a patient the other day who requested to have their bed turned to face the window so that they could see sunlight. And that did wonders for them. So.
And actually, what bed you're in, especially in RUH, because there's still 4-bed wards that do not have a window. Been there not that long ago. And it's horrible. Being able to see outside and sunshine or at least a piece of a tree makes a difference. It makes it a little more homey.
Yep.
So it helps.
Yeah.
So even if they can change the bed placements of a person that's at risk.
Okay. Liam, is there anything as practitioners that we can do to try and limit the risk of post-operative delirium?
I mean, there's all this sort of technical mumbo jumbo that exists of like, are there certain medications or anesthetics that we can provide? There's upcoming research on things like dexmedetomidine and Precedex. There's a bigger trend for measuring brain waves with processed EEGs in the OR to make sure that we're not over-anesthetizing our more frail patients. That's a big part of it. And I think the research is still up and coming on that. But I think it really comes down to sort of those standard good practices. I really think those environmental stuff, talking to people, checking on them after the surgery, and also just screening for delirium while they're in hospital. That's something that is cheap, very easy to do. I think of it as sort of like a 6th or 7th vital sign of we're checking blood pressure. We should be checking on how people's cognition is doing, because it's that sort of early recognition that maybe something isn't right. Maybe this person is a bit different than what they were at their baseline. That's how we are able to sort of intervene, talk to family, and do something about it in terms of moving beds and getting family in or those sort of stuff before it sort of gets out of hand and and progresses, right? And so those are just some things. And like, there's lots of research that's still coming out on what we can do better. But those are just little things of just knowing who's at risk, right? And screening for it, and just having the conversation, and talking that this is a very common thing. Like, I think something that really brought me into this was that it's extremely common. Like, it can happen in upwards of over 10% of people who come to surgery when they're over the age of 65. And I feel like it's just not talked about enough. We talk a lot in medicine about things like heart attacks and strokes, which are obviously very devastating. But this can be very emotionally draining and straining, and it's very common. And so just having that conversation with patients and other providers that this person might be at risk, you might see this is what it looks like, and this is what we can do about it, I think is just a great place to start personally.
And one more thing is, don't ever ignore what some staff member tells you.
Yes.
Sometimes it's the person that delivers the meals. They'll go, well, before the surgery, she always thanked me, and now she's kind of angry. Little things. So pay attention.
Early recognition sounds like it's key. Hey? Yeah. And then hopefully you can try to modify some of those environmental factors, at least at baseline.
Absolutely.
At the very least. So this has been a super enlightening conversation, and certainly making me reflect on my own practice and how I can change a little bit to be more aware of this, properly educate patients a little bit more. Any other comments, any other stories or anecdotes that you guys wanted to share?
I think we had been sort of discussing earlier that I think the big thing that needs to be done is a more collaborative approach, patient-centered. And like with my experience with my Nana, it was more my mom doing a lot of advocacy, because it was post-surgery, her surgical issue was figured out, but now she had sort of this cognitive issue, and surgery was not well equipped because that's not their expertise. And that's fair, but it was sort of what could be done to change the system to really integrate. So my family had to do a lot of advocacy to get a geriatric assessment, to get rehab involved. And I think we had been discussing, Heather, like those are things that may just need to be ingrained in how we treat older adults in hospital.
Yeah, older adults in hospital, they're already there. Maybe it's a good idea for anybody that's older in hospital that has potential cognitive issues to just have a look at it.
Yeah.
Yeah. Like you said, take the extra time while that person is there.
And yes, time is precious, but if you catch some of these things early, if you do the little things that will help, you may not end up with that person in long-term care for a few extra years. My dad might still be alive.
I am very sorry to hear about that.
It happened. It is what it is. But really, Mom never went home again.
And thank you for sharing again, Heather. I think it's super courageous, and it's stories like these that really hit home the importance of this issue and the importance of implementing new strategies to try and correct it, or not necessarily correct it, but help manage at least a little bit more.
Yeah, it's every little piece helps in the patient journey.
Right.
Yeah. Okay. Well, thank you both again. This has been an amazing conversation. And Liam, you touched on a few of the Grand Round episodes that we had done earlier this year. Alan, I'm assuming those are up on our ABC podcast already. So if listeners want to listen or get a little bit more information on post-operative delirium, those are already out there. So thank you both so much, and good luck with your project. I can't wait to hear more about it in the future. Yeah. And hopefully patients will start to notice that, or at least start getting screened and educated a little bit more as they come for surgery.
Absolutely.
Yeah.
Thanks, guys.
Thanks for having us.
Thank you.
Awesome. And thanks, listeners. We will catch up with you guys again for another episode very shortly. See ya.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.